debates on treatment of HIV, and another will be on use and abuse of antibiotics in medical practice. And infectious disease is something that is really close to my heart as well. So I am very glad to moderate this session. So first talk we are fortunate to have Professor Safdar Kamal Pasha. So regarding brief intro of Dr. Safdar Kamal Pasha, he holds master's degree in public health and business administration and fellowship in research and ethics from Global Institute of Public Health at Vanderbilt University, Nashville, Tennessee, US. Dr. Pasha has more than 30 years of experience in public health, including over 20 years of experience in HIV sector. He has worked with various UN and developmental agencies, including Global Fund, UNPFA, UNDP, and currently working with WHO Country Office's National Professional Office for HIV, Viral, Hepatitis and STIs. As a technical advisor for WHO in Pakistan, he supported development and upgradation of national and provincial strategic plan for HIV and hepatitis, in addition to upgradation of national HIV testing and treatment guidelines, national hepatitis B and C treatment guidelines in line with WHO global and regional guidelines in area of HIV, hepatitis and HIV. I humbly request Professor Safdar Kamal Pasha to please come on the stage and teach us. Thank you, sir.
Bismillah ar-Rahman ar-Rahim. With your permission, Chair, I'll be talking about an updates on HIV treatment. So basically, the format for my presentation would be as follows. I'll be talking about the HIV situation in the country, then few slides on WHO global guidance on HIV testing services in terms of new strategies and the approaches, HIV treatment services in terms of the new regimens and its application, then how these guidelines, the global guidance, has been translated into our national guidelines for testing and treatment. I'll be giving you an update of this transition from global to the national level, and then few gaps in the overall service delivery for testing and treatment in the country. Just a few words on the current epidemiological situation of HIV. We have an estimated around 240,000 people living with HIV in the country. There are around 27,000 new infections occurring each year. So this number is increasing every year. In the year 2021, 9,200 new cases were in fact disclosed or recovered. We have till now around 49,584 people who are aware of their status, which means they have been diagnosed and they have been registered, which makes it around 21% of the estimated PLHIV in the country. Out of these 49,000 or 50,000, around 29,626, which around 12%, they are receiving life-saving ART in the country. The ultimate aim for HIV treatment is to get the viral suppression, and just 8% of the total lot of around 29,000 who are on treatment at the moment, they are widely spread. For suppression, we need to have their viral load tested. Around 11,346 got their viral load tested, which is almost 50% of those, less than 50% of those who are in fact on ART. Around 8,600 new cases were started on ART last year. But I mean, you can see from this graph that Pakistan is among 3 countries in Asia Pacific region where the number of new infections are on rise. In fact, we have around 75% increase in number of new infection from 2010 to 2020, and is going beyond that. It's now 79%. Apart from this, we have one of the lowest testing and treatment coverage in the Asia Pacific region. As I just mentioned, the number of new infections, around 27,000 per year, they are on an increase. Next year, it will be more than that if we don't take appropriate action. So this shows you our regional position, how we are as regard the testing and treatment is concerned, the testing and the treatment coverage. Pakistan, unfortunately, at the moment, we are just ahead of Afghanistan, and you can see even the testing coverage of Afghanistan, they have more than what we have in Pakistan, 22 to 26%. But as regarding the treatment coverage, we are at number 2 in the Asia Pacific. So not only the number of new infections are on the rise in the country, but also we have we are facing the low testing and treatment coverage in the country. Not only this is the situation, but also whosoever is on treatment, those who are on life-saving ART, they face a lot of issues when they get to the treatment centers. There is a lot of attrition or loss to follow-up happening at the level of the ART services delivery. You can see from this graph, there is a huge gap, almost 20,000 gap among those who are registered at the various treatment centers. We have almost around 52 treatment centers all over the country, and those who are actually getting life-saving ARVs or life-saving ART at the treatment centers. So this is something alarming, that having policies of test and treat, and still we are having a lot of people living with HIV who are supposed to be on treatment, but still they are not on treatment, or they are not widely expressed. This is the testing and the treatment cascade. You can see around 240,000, and out of these 240,000, 49,000 are we have been able to reach around 49,594, almost 50,000. They know their status. They have been reached through various programs, service delivery as part of the HIV response. And out of these 29,000, they are on treatment. But the thing is, only just 8% or 6,990, almost 7,000, they are widely expressed, which is the ultimate aim of HIV service delivery in the country, to get those who are infected, to get them on ART and get them widely expressed. And if you look the same cascade in terms of the global commitment of global elimination target of 1990, which is 90%, we need to get to 90% of those living with HIV, so that they know their status, and out of which 90% they should be put on ART and 90% should be widely expressed. So I mean, on the left side of the graph bars, you can see that we are just not only behind, but way behind the global commitment for HIV elimination. The global guidance for HIV, just a few slides on HIV testing services and the global guidance. Basically, the global guidance for HIV testing services is based on 3 principles. One is diversity, simplicity, and demand generation. Diversity means adopting a differentiated service delivery, or rather differentiated testing approaches in terms of moving from facility level to community level, and even adaptation of HIV self-testing. Simplicity means that we should adopt the testing services which are more user-friendly and moving from expensive Western blot, time-consuming testing services to the rapid testing in terms of third test. As I mentioned, 3 different. So each client has to go through 3 rapid tests. Coming to the global guidance on treatment services, and this is just to give you a sense of how the guideline developmental process it takes place within WHO. So whatever the guidelines are developed, it goes through an extensive process of review and evidence generation in terms of data gathered through various modeling and studies, network meta-analysis, surveys, and the data that is routinely generated and collected from the countries and in fact analyzed at the level of at the global level. Then feasibility and the cost study, whether the guidelines they are cost effective and particularly the lower and middle income countries, they can afford it or not. Then values and preferences based on community and healthcare surveys and consultations. So it's a tedious, extensive process through which the guidelines are developed. So over the years, 2, in fact, very important development has occurred in the, as regarding the HIV policies are concerned. One is treat all policy, which means that those who are confirmed positive, they should be put on treatment immediately, irrespective of their CD4. I'll explain to you in my next slide. Then transition to new regimens, DTG, Dolutegravir, which has in fact revolutionized the HIV treatment globally. So we have the last guidelines issued by WHO in late 2019, and as I just mentioned, Dolutegravir, DTG, popularly known as DTG, is being recommended for first and second line of treatment for all the populations, including pregnant women and those who are in the childbearing age. To start with, there have been some studies which indicated some neural tube defects during early pregnancy in use of DTG. But now the empirical data is available, is relatively safe. It can be used by women in childbearing age. This DTG is a drug which is easier to take and has fewer side effect, only one pill a day. It can be combined with the other ARVs. So it's available in fixed dose combination. The studies has indicated that there are lesser chances for drug resistance as compared to the other ARVs. The clinical trials that has been conducted in various countries, they do indicate better safety and efficacy of DTG as compared to efavirenz, which was in fact used on a large basis. Almost 82 low and middle income countries, they have adopted this transition to DTG, and we are also in Pakistan, we are also in a process of transitioning to this DTG based regimens. So these are WHO 2019 guidelines, an update from them. As I mentioned, Dolutegravir in combination with nucleoside reverse transcriptase inhibitor NRTI is recommended as preferred first regimen for people living with HIV, both for adults, adolescent and infants. Efavirenz in low doses in combination with NRTI is recommended as alternate first line regimen. RAL-based regimens may be recommended as an alternative for infants and children if DTG is not available, so it can be used, but this RAL-based regimens, these are preferred first line for the neonates. So these are various combinations you can see. I'm not going to give you details of this, but only I can share that the preferred first line regimen is tenofovir, lamivudine, and dolutegravir. As an alternative, we can have tenofovir, lamivudine, and efavirenz. For the second line of ART, DTG in combination with optimized NRTI backbone may be recommended as a preferred second line if the client, they are not responding to the first line. Then as an alternative, boosted protease inhibitors in combination with optimized NRTI is recommended as a preferred second line regimen if the first one doesn't work or is not available. So these are various combinations, those are available for the second line of ART. Coming to the pediatrics ART optimization and the pediatric drugs. So basically the whole management is based on 4 principles, that is moving from non-NRTI based regimens. Second is introduction of DTG. So DTG is not only recommended for the adult but also for the pediatrics and for in ped regimens as well. Then use of most non-NRTI options and switching over to solid formulation as soon as possible. The recommended first line regimen is for the children is avidine, lamivudine, and dolutegravir, and is for the neonates, and for the children is abacavir, lamivudine, and dolutegravir. So for the second and the third line of treatment, both for adult, adolescent, and children, is two NRTIs and lopinavir and ritonavir. So a combination of these regimens in form of a fixed dose combination, and if this doesn't work, then 2 NRTIs and efavirenz, this is recommended. Just some points on or caution for use of these drugs for women. As I mentioned, that during the initial phase when this DTG was introduced, there was some data reported by some countries on neurological or neural tube defects. So subsequent studies have shown it to be quite safe, but still we recommend that during the first trimester of the pregnancy, DTG, if can be avoided, that would be more feasible for the client. Or the client can be advised to have an effective contraception during the period. And just to sum up, DTG has been preferred first line for every living with HIV with approved dosing. Efavirenz 400 milligrams or in lower doses is recommended as alternative. Boosted protease inhibitors alternative RAL can be considered an alternative to lopinavir and ritonavir, the alternative drugs, those are available. But for the neonates, the RAL is recommended. Apps are available where all these guidelines are available. So just a few slides on what actually we are implementing in the country. As I mentioned in my previous slide, that we are following HIV test and treat strategy. That is, ART should be initiated in all the individual regardless of their CD4 count. So this is what we also call treat all. So immediately who are diagnosed or discovered with, of course, after going through 3 tests, so they should be immediately put on the treatment, preferably on the first visit. But some of the client, when they come to the treatment center for the first time, they need to have adequate social support. So the combinations that are being applied in the country at the moment, it consists of 2 nucleoside reverse transcript inhibitors, NRTIs, plus an integrase strand transfer inhibitor, INSTI, and the regimen that is being followed, the combination that is being followed is consists of tenofovir, lamivudine, and dolutegravir, DTG. Then various alternatives are also available in the country, and in fact there are 6 drugs: lamivudine, efavirenz, tenofovir, abacavir, and DTG. These various combinations are also available in the country. For the pediatric, either to start with or to transition, as the formulation is based on weight bands. For more than 30 kg is the same as the adult one, which is tenofovir, lamivudine, and DTG. For weight band of 20 to 30, the tenofovir is replaced with abacavir. For 5 to 20 kg, the same combination, we add the LPV is added. But for weight band up to 5 kg, the combination is slightly different, and nevirapine is added to the combination. For monitoring of the client, the treatment monitoring, in fact, there are 2 type of monitoring. One is the immunological monitoring, the other is virological monitoring. So we recommend the virological recommended, that is the viral load testing of all the client on ART at least twice a year. As regards the CD4 count, the immunological monitoring. In adults, the CD4 count is not required, or it need not to be repeated if the CD4 count is more than 350. But if a opportunistic infection is suspected, the CD4 count, they give an idea about it, so it can be repeated. But for the children, the cutoff is more than 750. So if the CD4 count is more than 750, so no need to repeat, except when it is required to determine the safety of viral live vaccine suspected of OIs. But in each case, reinforcement of adherence is very much required. Then treatment failure. Second line treatment for adults and children, it consists of 2 NRTIs and ritonavir based protease inhibitor. So again, Dolutegravir, DTG has been recommended as the second line. Apart from that, in the second line regimen, tenofovir should be switched to zidovudine, and vice versa, and lamivudine should be continued. A few words on advanced HIV disease. We define advanced HIV disease as 5 years. Is defined as CD4 count of less than 200, or WHO clinical staging 3 and 4 at the time of the presentation. So there is a package of services available to manage the advanced HIV disease, which includes the management of OIs, rapid ART initiation, if not already started, intensified adherence, interventions in sport, and counseling on continuation of the treatment. And what we recommend is there should be a referral pathway or mechanism should be available, so that those with the advanced disease, they should be immediately referred to a specialized center for management. This is a very important slide, and just to show you the AR regimen data, that is data from ARV regimens that is being in practice in the country at the moment. So for the adults, you can see that the almost 70% at the moment they are getting dolutegravir, lamivudine, and tenofovir as first line. So DTG has been transitioned in almost over 70% in adults in Pakistan. But when it comes to pediatric ARVs, DTG is a low priority, and the most commonly prescribed regimen is nevirapine, lamivudine, and zidovudine. So just summarizing, for treat-all, as I mentioned, the treat-all strategy, which in fact WHO came up in 2015. So we have a huge gap as regards the treat-all strategies concerned. Okay, thank you. So we have a huge gap for it. Around 98% of our PLHIV who are in fact on treatment, they are getting first line, and majority, in fact, DTG is in fact in adults in almost 70%. My last slide. But the major gap that we are facing at the moment is a loss to follow-up, a great loss to follow-up among ART clients who are registered and getting ART services at the treatment services. Relatively, the viral load monitoring is quite a bit of concern. We don't have a system available in the country to monitor the HIV drug resistance, and we hope that this system, the surveillance system for HIV DR, will be established in the country very soon. We don't have a system for pharmacovigilance for ARVs. In fact, the other phenomena, which is in fact, though we have more than 50 treatment centers in the country, but still the treatment coverage is low because we don't have a decentralized or differentiated service delivery services available for the treatment in the country. I mean, this is this is a concern in a sense that we have the treatment centers available in the country in the major cities, but down the service delivery, we don't have the services for HIV or even for hepatitis available. Hepatitis to some extent is available, but for HIV is confined to the major cities and to urban cities only. But the lower down in the primary healthcare, we don't have the facility for HIV available. We don't have PPT-CT services available with all the treatment centers, and if you compare the PPT-CT sites with the ART sites, so these are very small numbers. Though WHO has recommended prophylaxis for HIV prevention PrEP, but still it hasn't been implemented in the country as yet. Formally it has been implemented, not yet implemented. So I'll stop here, and if there will be any question, I'll be happy to respond. Thank you.